Victor. Hugo Perez is a dear friend of ours from Mexico. He's an amazing neuroanatomist. He's done some amazing work, and we have had the pleasure of listening to him and seeing all his models. I've got some of his models with me in my clinic as well. He's been a member of the Neuroanatomy committee in the past, and he's from Mexico City, and I'm delighted to have him here. And I'm sure all the young people will learn loads from him. Victor, all yours.
Thank you so much, dear Professor Salman. It's very nice to see you, Dr. Ahmed, Dr. Salman, and everybody that is coming to this lecture. So first of all, it's a honor for me to be here. So another thing that I am really happy, we are going to organize the World Congress in 2020, in 29. So I hope to see you here in Mexico. Mexico is really a very nice place to visit. So
Definitely.
let's start. Let's start with this talk. I'm going to talk about the gross anatomy of the spinal cord and also the vascularity. Um, I'm going to talk first of all about some really basic aspects of anatomy, but I think this is not for expert brain surgeons, but for beginners and also for residents, this information is really good. So the extent and length of the spinal cord in adults is going from L1, from the foramen magnum to the level or to L1 and L2 vertebra. The average length is about 45 centimeters in males and 42 centimeters in females. The entire adult vertebral column measures about 70 centimeters. So in the right side, we have a really nice drawing of Dr. Netter, where we can see the posterior aspect of the spinal cord. Um, the shape of the spinal cord is cylindrical in the upper cervical and thoracic regions and oval in the lower cervical and lumbar regions due to limb innervation. The developmental change, the termination level changes with growth because the vertebral column grows faster than the spinal cord. Early fetus spinal cord occupies the entire vertebral canal. Term newborn cord reaches the lower border of L3. In late adolescence or adult, cord ends at the intervertebral disc between L1 and L2. The spinal cord enlargements. The spinal cord has two enlargements, the cervical and lumbar. The cervical enlargement is going from C3 to T2 spinal cord segments and is related to innervation of the upper extremities. In the lumbar enlargement is going from L1 to S3 spinal cord segments, and this is related to innervation of the lower extremities. In the right side, we have again another beautiful picture or drawing of Dr. Netter, and we can see in here the posterior aspect of the spinal cord with dura mater, the subarachnoid, and the pia that is attached to the spinal cord. And here we have the posterior nerve roots of the spinal cord, and the dentate ligament in this side. So the conus medullaris and filum terminale. The caudal end of the spinal cord tapers into the conus medullaris. From the conus, the filum terminale apial glial filament extends downward and attached to the coccyx, helping the anchoring of the spinal cord. and denticulate ligaments. The spinal cord is also anchored to the dura mater by denticulate ligaments. These are lateral pial folds extending from the spinal cord surface to the dural sheath, and they attach midway between the dorsal and ventral roots. The spinal cord, these are some key concepts. The spinal cord is a cylindrical structure extending in adults from the foramen magnum to the level of the second lumbar vertebra, where it terminates as the conus medullaris. Here we have the foramen magnum, and here we have the conus medullaris in this side. Okay. The spinal cord has two enlargements, as I told you, cervical and lumbosacral, corresponding to regions innervating the upper and lower extremities, respectively. There are 31 pairs of spinal nerves, grouped into 8 cervical, 12 thoracic, 5 lumbar, 5 sacral, and 1 coccygeal. The S4 and S5 and coccygeal nerve arise from the conus medullaris. Spinal nerves exit the vertebral canal through the intervertebral foramina. C1 exits above the atlas, and C8 exits between C7 and T1, and all other spinal nerves exit below their corresponding vertebra. Each cervical spinal cord segment has dorsal sensory roots and ventral motor roots. This is a picture about the spinal cord, in which we can see the arachnoid, the dentate ligaments, and the anterior nerve root. I think there was a problem. Oh, no. Okay, let's go. Near the junction, the dorsal root contains an enlargement called the dorsal root spinal ganglion, which houses pseudo-unipolar sensory neurons. Where the dorsal root enters the spinal cord, there is a sharp transition between central nervous system support tissue glia in this side, and peripheral nervous system support tissue, Schwann cells, and collagen. This boundary is called the Obersteiner-Redlich zone space. Because the spinal cord and vertebral column grow at different rates, spinal cord segments don't line up with the same numbered vertebra. Cervical region, the vertebral spine tip, corresponds to the next spinal cord segment. For example, C6 vertebra and C7 cord segment. In the upper thoracic region, the vertebral spine tip is 2 segments above the cord segment. Example, in T4 vertebra, we have the T6 cord segment. And in the lower thoracic or upper lumbar region, the difference is 3 segments. For example, T10 vertebra is L1 cord segment. Because of this increasing mismatch, spinal nerve rootlets travel longer distances, especially toward the sacral levels, to reach their intervertebral foramina and the crowded bundle of lumbosacral roots around the filum terminale is called the cauda equina. The spinal cord is covered by 3 meninges. Pia mater is the inner meninge, then arachnoid mater and dura mater. Here we have a picture about the dura mater inside the vertebral channel. So here we have the dura mater of the spinal cord. The pia mater has 2 layers: intima pia, tightly attached to the spinal cord, and epipia, contains blood vessels and forms the denticulate ligaments. The arachnoid mater is closely attached to the dura mater. The subdural space between the dura and arachnoid is very narrow and a potential space. If a bridging veins rupture, a subdural hematoma can occur. The subarachnoid space between the arachnoid and pia mater is wider and contains cerebrospinal fluid. The spinal dura mater is firmly attached to the bone only at the foramen magnum. Between the dura and the vertebra is the epidural space, which contains fat and a venous plexus. It is used for epidural anesthesia. Here we have the inner aspect of transverse cut of the spinal cord, where we can see the elements, the anatomical elements, tracts that are going to the spinal cord. For this is a matter of other lecture, of course. So now we are going to talk about the vascularity. And let me tell you something. For me, it's impossible to talk about vascularity without mention this great professor Adamkiewicz, because he discovered this interesting artery of the spinal cord, Albert Adamkiewicz. Albert Adamkiewicz drew these drawings in 1881, 1882, showing arterial vasculature of the spinal cord and the bidirectional flow of blood in spinal cord vasculature. Here we have a representation of the anterior, of the great anterior spinal artery, known as Adamkiewicz artery, that has a special flow, the great flow to the lumbosacral region, but it connects to the thoracic artery to irrigate the thoracic aspect of the spinal cord. And in the left side, we have the two vertebral arteries giving rise to the anterior spinal artery. And in the right side, the conus medullaris with the ending of this anterior spinal artery. In that time, these pictures were really nice, really good to understand basic anatomy of this artery. And this is Adamkiewicz injected arteries and veins with some special method using Teichmann mass, using this kind of elements. But now it's easier to do that, and of course, in many countries, this kind of work has been done, especially in the United States and Europe, also in Asia, I think now in all the continents. But now it's easier. I think the difficult thing to make this work is to get some specimens. But if you could have some of these specimens, you can inject this with silicone or also latex. So in color red, we have the arteries. In this picture, we have in the left vertebral artery, dominant, is a dominant vertebral artery, and hypoplastic right vertebral artery. They are giving rise to the spinal, to the anterior spinal artery that is running in the anterior side of the spinal cord. I'm going to show you some pictures about this beautiful anatomical region of the human body. So here we have the anterior spinal cord. This is an aspect of the anterior spinal cord in which we can see the Adamkiewicz artery. This is this artery. We can see also veins injected with color blue and the anterior spinal roots. This one. And in this view, we can see the posterior nerve roots And in this picture is very important because we can see the main two arteries that are irrigating the spinal cord, especially the lumbosacral segment. In the anterior aspect, the Adamkiewicz artery, and in the posterior aspect, we can see this artery. So maybe you recognize this artery. This artery was studied about 60 years ago, and its name is the great posterior radiculomedular artery. Radiculomedular artery because this artery is running along the posterior nerve root, and that is the origin of the name, radiculomedullary artery. So both arteries irrigate the anterior and posterior aspect of the lumbosacral segment of the spinal cord. And in this picture, this is really beautiful. We can see here the lateral aspect of the lumbosacral segment of the spinal cord, including the conus medullaris. So let's go to identify these arteries. So this is the anterior aspect, this is the posterior aspect, and this is the lateral aspect. These are the dentate ligaments, and in this picture we can see the really nice anastomosis between the anterior, the Adamkiewicz artery, and the posterior radiculomedullary arteries. This is the posterior spinal artery, this one. And in the conus medullaris, these arteries have the main anastomosis. So here we have this rich anastomosis and these vessels that are coming from this. And look this anastomosis between these two main arteries. Here we have a posterior aspect of the spinal cord in which we can see the both posterior medullary arteries, this and this one, the right and the left. And also we can see the a great vein, drainage vein, main drainage vein of the posterior aspect of the spinal cord. What I have been doing to inject these arteries. First of all, to get the specimen, now is also in Mexico is difficult to make this kind of work. It's not easy, but I have the opportunity to make this in the Forensic Sciences Institute. What I have done is to inject the silicone into the Adamkiewicz artery. Let's go to show you this injection. So look at this. This injection is going to fine vessels, very small vessels. You can reach these small vessels doing a good injection of the silicone. In the right side, we have like a fluid outside the arteries. So again, look the spinal roots nerve. For example, here, look at this. this is really nice because with this injection you can reach very small vessels. And here we have a picture after the injection. So this anterior radiculomedullary artery is in the anterior aspect of the spinal cord. It took a characteristic hairpin. The preoperative localization of this artery is very important in some surgical transthoracic spine procedures, and also in neurosurgical approach to the posterior spinal cord. Here we have the characteristic form of this Adamkiewicz artery, like a hairpin. So in 50 spinal cords that we studied, left-sided vessels was present in 45 specimens, and a right-sided Adamkiewicz artery was present in 5 specimens. This is in the right side. Here we have in the left side. And although variability exists to the overall caliber of radiculomedullary arteries, dominant radiculomedullary arteries are present. The most important radiculomedullary artery is the arteria radicularis magna, otherwise known as Adamkiewicz artery. This artery arises in the thoracolumbar region between T8 and L2 in 75% of patients, and has a diameter of approximately 1 millimeter. So in this picture we have this Adamkiewicz artery. It measures, as I told you, about 1 millimeter of diameter. So and I want to compare these two images, this and the below image. For example, in this case, this is a thoracic artery. Look the size of this and this. This almost measures 100 or 200 micras. The difference is very enormous. So irrigation of the spinal cord, the preoperative localization is very important, and the anatomical knowledge gained preoperatively may reduce the risk of postoperative paraplegia. So I'm going to show you some variants. For example, in this case, the Adamkiewicz artery didn't arise from the thoracic. It arises in the thoracic, but in the highest level. It is coming from T3. So here we have the nerve roots 1, 2, 3, 4, 5, 6, 7, 8. 1, 2, 3, 4, 5, 6, 7, 8, and 1, 2, 3. It is coming from T3 in the left side. So this was found in the highest level of the 50 spinal cord studies. So key concept is the spinal cord is anchored to the coccyx by the filum terminale and to the dura mater by the denticulate ligaments. Look at this picture. Here we have the denticulate ligaments. In this case, here, 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 and here. The artery that arises from the lowest level was found in left L2, in the left side, L2. So here we have this Adamkiewicz artery. This is a really nice picture to show this artery. And in the next, I displaced the nerve roots to see the lateral aspect of this spinal cord. Here we have this artery in the lowest level that we found, L2 in the left side. This is the anterior aspect and posterior aspect. And again, look at the really nice, beautiful, and useful anastomosis between these two arteries. In the anterior aspect, the Adamkiewicz artery, and in the posterior aspect, the radiculomedullary arteries. For example, the great posterior radiculomedullary artery. So this is the posterior spinal arteries. And the anastomosis in the conus medullaris between these two arteries. So this is a table to show the artery of Adamkiewicz side and level of origin. As you can see, the most important spinal level was in thoracic 9, in which we have the origin of 13 Adamkiewicz artery, and in T8, 10. So in this case, we have two anterior spinal arteries, this and this one. So anatomy of the great posterior radiculomedullary artery. This artery is really a special, how to say you about this. This is a special feature because the knowledge of this artery is not common, is not well referred in some texts or articles, and understanding the basic vascular anatomy of the spinal cord is very important for imaging interpretation and endovascular and surgical management of spinal cord vascular malformations. Here we have the posterior aspect, and in the posterior aspect we have two posterior spinal arteries, each one in each side of the spinal cord. For example, left side and right side, and they have a very nice anastomosis between them. And in this case, we have the great posterior radiculomedullary artery. So this artery was discovered about 70 or 80 years ago, no more. So this is really interesting. Let me show you this. For example, the existence of this artery has attracted little attention and has been a matter of debate. Various authors postulate such a vessel. For example, Gillian in 1958, Lasortes 1957, Romanes 1965, and Jellinger. But others do not mention it or even deny its existence. For example, Corbin in 1961, but also in the late 1980, Domis deny the presence of this artery. So according to Jellinger, a large posterior radicular artery is in caudally in about 75% of instances, but its caliber does not approach that of the large anterior vessels, and its diameter is about 350 and 500 microns. Its height is more caudal than that of the anterior radiculari magna artery. So now there is no doubt about the presence, about the existence of this artery. You can see in this picture the Adamkiewicz artery in is this, and in this is the great posterior radiculomedullary artery. No doubt about its existence. So in this small video, I can show you the running of this great posterior spinal artery And this is the posterior aspect of the spinal cord. Here we have the conus medullaris.
This is a great posterior radiculomedullary artery. It is coming along to the 12th thoracic nerve root in the right side. This artery makes a curve and goes to the posterolateral aspect of this spinal cord. Then returns to the posterior aspect between L3 and L4 nerves. Great posterior radiculomedullary artery. Here we have the posterior spinal artery that is coming from the Adam-Kirich artery. This is the posterolateral aspect of this spinal cord. Here we have the posterior spinal artery. This artery is going to make a beautiful anastomosis with the great posterior radiculomedullary artery.
So this artery was identified in our studies in 72% of spinal cord specimens. This total included specimens in which unilateral and bilateral GPRAs were found, as well as a single case in which three arteries were evident. In 26% of the specimens, a unilateral left-sided GPRA was present. A unilateral right-sided was present in 22% of the specimens. Here we have these pictures to show this fantastic great posterior radiculomedullary artery. So it's very important to know, to study not only the arteries of the spinal cord, also the brain, veins, arteries, because if we know a little bit about the anatomical aspects or features about these arteries, we don't have a good view. But if we study and we continually are studying these arteries, the view is wide and is much better, very clear. So that's the reason it's very important to study these topics, especially for residents, for beginners in this field of the neurosciences. So in 22% of the specimens, bilateral GPRA were present, 11 from 50 spinal cords studied. This is the table about the distribution of the great posterior radiculomedullary arteries based on side and spinal level. In T12, in the left side, we found 9 arteries, and in the right side, also 9. So this artery is found in both sides. So what I told you, there is no doubt about its existence. Here we have very clear this great posterior radiculomedullary artery coming from left T9. Conclusions is GPRA is conclusively present in most individuals, 72%. Understanding this intricate anatomy and its variation is critical for addressing vascular malformation of the spinal cord. A better understanding of the spinal cord circulation will lead to reduced risk of surgical and endovascular spinal and aortic procedures. So now let's talk a little bit about irrigation of the thoracic segment of the spinal cord. Regarding the anterior thoracic arteries of the spinal cord, we found the dominant anterior thoracic artery. We name this artery as DATA, dominant anterior thoracic artery, which was identified between T1 and T11 in 94% of the specimens, being the most frequent site at the level of T4 on the left side. The average diameter of these arteries was about 450 microns with a range of 270 and 260 microns. At least one data was evident in 94 of spinal cord specimens. A single data was present in 66% of the specimens, and the data were identified in 26%. Three data were identified in a single specimen, all arising 2%, all arising on the left at the level of T3, T7, and T9. So look at this injection of the thoracic artery. Is also a really nice video. Here I am injecting this artery, the data dominant anterior thoracic artery. I'm going to repeat this injection in the thoracic segment of the spinal cord. So I have showed you these videos. They are spectacular, and we can get good information about the drainage vein of veins in the spinal cord. For example, in this specimen, we had this kind of drainage, and in this we had another form, a variation in the drainage vein. So if you analyze the vein drainage of these spinal cords, let me show you again. In the upper view, you can see only 2 or 3 dominant vessels, vein vessels. For example, in here, this one, the most important, and also this and this. But what happened in the inferior view? Look. In this, we have numerous veins draining the spinal cord. Numerous veins. Here, 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 here. So in here we can make a question. So if we are going to operate a simple disc, an extruded disc in the spinal cord, and we have a vein that is damaged in the surgery, and most of the times of some spine surgeons cauterize, close that bleeding. So we should be very careful to avoid the cauterization in all the veins. It's much better to make some pressure with cottonoid instead of close the drainage. Because if you have, for example, if you are closing this main vein, you could have a problem in the drainage of the spinal cord. Here we have numerous, maybe in here we don't have problem. So the great spinal anterior vein, you can see in this picture, this is the great anterior spinal, and the diameter average is about 8.8 millimeters, but is bigger than the arteries. Here we have another aspect, anatomical variance of these veins. These veins measures about 1.48 millimeters. In both sides, the posterior spinal arteries. Here we have another variation of these veins in the posterior aspect of the spinal cord. So we have two articles published in the American Journal of Neuroradiology. This the first article was published with Dr. Juha Hernesniemi and also Juan Small. So I think this is the last slide. So thank you so much for your attention, and I feel really honored to be here with you, dear friends.
Awesome, Victor. I think it was so superb, really mesmerizing, amazing slides and videos, and all of us really enjoyed, and we learned loads from it. As always, you've delivered amazing work. I'm grateful. If there are any questions, we'll be happy to take them.
Thank you so much, dear friend and Professor Salman Sharif, and congratulations for your new position in the World Federation.
I'm grateful. Thank you. No, I think the most important, how did you how did you get involved in making all these amazing specimens? What really happened?
I was involved. I started 36 years ago when I was doing my second year in my residence in the hospital. I felt the necessity to learn more anatomy, to be more sure, to be surer in the beginning of my specialty. So that's the reason I was involved doing this kind of injections. And in that time was really easy to make these injections. Now is some difficult to get some specimens.
Okay, brilliant, brilliant, brilliant. Atabati wants to ask a question. See if he can. Yes,
Excellent,
Atabati, please.
Professor Hugo. Excellent specimens and details of anatomy. I have a question. On these cadaveric, we see PL and epidural level vessels. My question is, what happens to the transsulcal vessels, what we call as transsulcal perforators, and at the cross-sectional level? Do you always see the posterior radicular arteries as a stem?
Um, I have not. I'm not doing uh, until now cross sections, transverse sections to see the running of the small arteries inside the sulcus. So I don't have a response to you in this question.
Right. My observation during digital subtraction angiographies were to have a very beautiful transsulcal supplies, especially in pathologies like AVM and dural AV fistulas. They become more prominent. And angiographically, the anterior transsulcal parts, there are described AVMs which are in relation with the Adam-Cavix, but they can be approached through selectively into the transsulcal area once the normal supply is very much distinguished. One thing. Second point is the anterior artery is always defined in the sulcus, but the posterior is more like a plexus network, as you beautifully mentioned, the laterality in the posterior greater radicular artery. So the posterior plexus is more abundant anastomosis. And in the cross-sectional level, they supply the posterior 1/3 of the cord. So when we are dealing with the anterior side, it's always tricky and more careful once we catheterize. And there are now the catheters are very soft and navigable, and navigational skill is more harmless because of the soft nature. So that's the comment I wanted to make. Thank you so much for refreshing details of spinal cord anatomy. Thank you, Professor Hugo. Always a pleasure to hear you.
Thank you,
Thank
Atar.
you.
There's another question from Ahmed Al-Ghanimi, and he's asking, in which cases the occlusion or injury of the artery of Edenkiewicz will lead to paraplegia, and when its occlusion doesn't lead to paraplegia? Is there any cases where you take the Edenkiewicz and it doesn't cause paraplegia, and which specific cases it will cause paraplegia?
This question is written in the chat.
Yeah, it's written in question and answer on the right side.
Okay, I can see that question. So please, Dr. Salman, can you repeat?
Yeah, so the question is, in which case the occlusion or injury of the artery of Edenkiewicz would lead to paraplegia?
Okay, I think it's not common. It's very uncommon to lesion that artery. What I have seen in my studies is that in most of them, almost 70 to 80%, there are really a very nice anastomosis between the posterior, the great posterior radiculomedullary artery with Adamkiewicz artery. But I think that if you lesion all completely the Adamkiewicz artery, so we are going to have some damage in the spinal cord, because I think it's not enough the flow of the posterior radiculomedullary artery. The Adamkiewicz artery is about 1 or 1.2 millimeters. And the posterior artery is about 300, 400. The difference is very big. So I think that's the reason we should be very careful to not damage these arteries. None of them. I have not seen paraplegia due to this.
Yeah, I think what's happened previously, anytime we used to approach these levels, we used to get an angiogram to see where exactly the artery of Edenkiewicz was, but we don't do that anymore because we haven't seen a worsening of symptoms in these patients at all.
Okay.
There's another question, and this is from Ahmed Hazim Al-Ghori, and he's asking that, he's saying, thank you for amazing lecture. Anterior radiculomedullary artery has more predictable location than greater great posterior one, but in all situations, we will need preoperative CT angiography. So he's saying that, we know that there's difference between anterior and posterior, but do we need preoperative CT angiogram in every case?
I think no. If you are going to make an approach, for example, in some metastases, in some neoplasia in the where this arterial located is very very necessary. But if not, I think it's not necessary to do that.
I'm grateful. I think amazing. We have no more questions. I'd again like to thank Victor, and I'm really grateful to Ahmed Saleh Al-Jardi. As always, he's been very kind and gracious in hosting the Yemeni Society, and the World Federation, the Pakistan Society of Neurosurgeons, and the WFNS Young Neurosurgeons. I think all of them are contributing, and it's amazing to have such brilliant lectures from an awesome speaker. So I'm grateful. Do you want to say a few words, Ahmed and Ahmed? Would you like to say a few words?
Thank you very much, Professor, and thank you for your support to our education activity and to the activities of the Yemeni Neurosurgical Society. And are we very honored for your participating, you and for Dr. Victor, for this amazing presentation. And also thank you, Dr. Riaz Raja. I see him here also, head of Pakistan Society of Neurosurgeons, for your advice and for your support to these activities. Thank you all very much.
Thank you so much. I'm really happy to be with you.
Thank you very much. Riaz, would
Thank
you
you,
like
Professor.
to say a few words before we close? You have to unmute.
Excuse me.
I will pay thanks to Victor Hugo from the Pakistan Society of Neurosurgeons and to Yemeni Society that this program is very beneficial for the undergraduates and even for the postgraduates and also the consultants, that every time we are updated with the knowledge and skills, and we also learn from the juniors and also from the seniors. Thank you so much.
Thank you. Thank you. Thank you.
Yeah.
Thank you, everybody. Wonderful to have you all and hope to see you again soon.
Thank you, everyone.
Thank you and bye-bye.